Hello, and welcome to this global town hall meeting on COVID-19 and viral hepatitis. My name is Cary James, if I haven't met before, and I'm the CEO here at the World Hepatitis Alliance, and we're absolutely thrilled to have so many people from around the world join this very important meeting. So the format of today will be, we'll have a couple of presentations to start with, one from the WHO and one talking about the survey that many of you filled out that we've done at WHA. And then after that, we're going to hear from many of you from around the world about your stories about how you've been affected by the current crisis, how your services and how your service users and communities of interest have been influenced and impacted by the current crisis. So we really want it to be a kind of like a very interactive session. This is really about all of us getting together and discussing. So we're actually learning this technology just like so many other people in the world. So there might be a few hiccups on the way, so please bear with us. And we're gonna absolutely try to keep to time, but you know, I think if we go on a bit longer, then I'm gonna probably allow that to happen. And then if you have to go, you can catch up on it because we're gonna post this online afterwards. So first, I would like to just ask our president, Sue Wang, to give us a welcome message. So Sue.
Great, thanks, Cary. Well, just as an introduction, I'm a primary care physician on the front lines as well, seeing patients, and I am also living with hepatitis B and proud to serve as president for the Alliance for the next 2 years. I want to welcome everybody to our first virtual town hall. We had more than 200 registrants, and we're hoping we can do more of these in the future so we can accommodate different time zones, languages, and regions. So first off, I want to say I know that COVID-19 has significantly impacted all of you. We can probably all say that our day-to-day lives now look quite different from just 3 months ago, and not just personally, but also in our work. We know that so many of our members work directly with individuals and communities. You all are providing critical services for hepatitis screening, education, and care. And we know that all those services have been impacted by COVID, whether due to physical distancing, stay-at-home orders, lack of transportation, or simply from the fear that people have from accessing these services. We know that it can be an uncertain time for organizations and staffing, as the economic and financial impact of COVID cannot be understated. So we think it's a really critical time for us to connect and to encourage each other and perhaps provide each other with solutions we hadn't thought about, or the hope that comes from just hearing each other's stories. So as we all know, many meetings have been canceled where we would have benefited from being in each other's company. So in this time where we have to be apart, it's great that we can actually convene in a digital way. We are extremely excited to have Philippa Easterbrook here from WHO to give us an insightful and timely update about COVID. Niklas Luhmann from WHO will also be commenting. And we're very proud to have members from India, Canada, and Uganda sharing today about their on-the-ground experiences. So we hope this is a time for all of us to be able to tap into this amazing network of people that we have that spans the world to share ideas and advocate for those living with hepatitis in our communities during this difficult time. Thank you. Back over to you, Cary.
Brilliant, thanks, Sue. And just to kind of explain how it's all going to work. So we'll be giving the presentations and we'll be kind of curating everything here. If you have a question or would like to share your experience, please type it into the Q&A section, the question and answer section. And those will be relayed to me, and then I can ask those to the panelists. And so without any further ado, I'll turn it over to Philippa Easterbrook, a great friend of WHA, and she's from the Global HIV, Hepatitis, and Sexually Transmitted Infections Programs team at Geneva headquarters in, WHO headquarters in Geneva. So Philippa, over to you.
Hello, good morning, afternoon, and evening, everybody. And thanks to Sue and Cary. And it's really a great pleasure to be here. Thanks so much for the opportunity for WHO to join this important town hall meeting. And certainly at headquarters, there's now a real encouragement that we sort of share some of the messaging and the range of activities that WHO is undertaking And certainly it's been a learning lesson. It's been a lesson for me in understanding the myriad of activities, many of which I hadn't been aware of before, that WHO's engaged with. So I'm going to just highlight some of the key activities in the WHO response that I think will be of particular interest to this fora. Next slide, please. Slide number 2. So I'm going to begin with a very quick recap of the timelines of the key events over the last almost 5 months, and many of these will be familiar to you, starting with 31st of December 2019, when that first report was made to the WHO country office in China of a pneumonia of unknown cause detected in Wuhan. And this then led to the immediate activation of the WHO IMS, or Incident Management System. That's how it works with new outbreaks. And on the 10th of January, WHO had sort of assembled and issued its first package of comprehensive technical guidance on how to detect, test and manage potential cases. And that then was followed on the 30th of January by the declaration of the outbreak as a public health emergency of international concern. And then 4 days later, the launch of the Strategic Preparedness and Response Plan that I'll mention in a moment. And then finally, the 11th of March, declaration of COVID as a pandemic. And now turning to the graph on the right, which shows the trajectory of the number of cases from January through mid-May by WHO region. So you see, starting on the left, the early on in China, the outbreak captured in orange, and then this explosion of cases in the European region shown in the red bars, and then subsequently the Americas, particularly the United States, shown in yellow. You see the Eastern Mediterranean region, that includes the countries of Egypt and Pakistan, and that's shown just between the red and the yellow in purple. And then the cases from the African region are in green, right at the top, still fairly small. So I think you can see from this overall picture what we now know are encouraging signs with declining cases in Europe, but in other regions, just seen right at the bottom of the graph, such as Southeast Asia, as well as Africa, the Caribbean and parts of South America, the numbers are still rising. Next slide. So as of June 1st, we now have more than 6 million confirmed cases reported from 215 countries or territories and 370,000 deaths. And when I gave this presentation just a few weeks ago, we were at just nearing 4 million, and it was just over 150,000 deaths. So just in this short period of time, this escalation. So really a grave milestone. And then the map on the right shows the cases in the last 24 hours with shading according to the intensity. And this is cases per million of population. So there's been 119,000 confirmed cases and about 4,500 deaths over the last 24 hours. And I think this is the first point to emphasize in terms of WHO activities, that the WHO's got a unique function in collating the health information for global action. There are obviously other players, the Johns Hopkins database, but this is very important for driving the data and the analysis. And we get data from 215 countries and territories, as well as case-based data from 126 countries. Next slide. So what is WHO doing? Well, WHO's been doing what it always does in response to an epidemic. So that is to analyze data, provide advice, coordinate with the partners, and help countries prepare, as well as addressing the supply challenges. And so I've just highlighted some of these areas that I'll just flag in some subsequent slides. And that includes the scaling up the country preparedness and response plans, addressing the priority research and innovation, And very importantly, the rapid assessment of evidence and generation and continuous updating of technical guidance and the scientific briefs, and that overall coordinating function and risk communication. Next slide, slide number 5. So this is a busy slide, but it is a document, this global preparedness plan that was released just 4 days after declaring COVID as a public health emergency of international concern, and has now just been updated. And there are 5 strategic objectives. Again, this will be familiar to you, but it is the centerpiece of the country's support and activities. Number 1, that there should be mobilization of all sectors, government and communities, in the response in preventing cases, hand hygiene, physical distancing, and the rest. Then there are the 2 very strategic, the controlling the sporadic cases and clusters and preventing community transmission by all the key steps. You need to rapidly find and isolate and manage cases, provide them with care, and contact trace and quarantine and support the contacts. And that's what, of course, many countries are now in Europe going through, that developing that capacity as they move out of the so-called lockdown. Then the key issue of suppressing community transmission, and that's been the phase many European countries have been in through all the appropriate infection prevention and control, the physical distancing, restrictions on domestic and international travel. And then, of course, clinical care. To reduce the mortality, you need to have your optimal clinical care pathways in place, ensuring continuity of the essential health services so that you're not just focusing on the COVID, but the other essential services, and protecting frontline workers. Next slide. And I think this is slide number 6. So this is pulling together the data monitoring capacity with the support for country preparedness. And I think this shows quite nicely on this slide some of the metrics. This is not obviously assessing quality, it's just a country reporting whether they have or have not. So now pretty good country preparedness plans in the majority of country. There's been good communication strategies put in place, 95% reporting they have a community engagement plan. But where there is perhaps some weakness, you see on the bottom here, is having good surveillance schemes in place. Only 73% of countries reporting this. And then also right on the end here, there's some weakness in the infection prevention and control standards in health facilities. Next slide. So another very important area is the coordinating function with respect to research. So as you're all aware, there are no currently licensed therapeutics for COVID-19, other than some of these emergency access schemes that are available. But many, many clinical trials are underway, and you're reading of them, I'm sure, all the time in the literature. There's been, more than 15,000 scientific papers published over the last 4 or 5 months, which is really quite phenomenal, a doubling time that exceeds that of the COVID virus itself. And so WHO really systematically tracks all these publications that are emerging, even pre-publications, and that forms the basis of our rapid response in generating recommendations. And a really key point from WHO is the importance of evaluation of therapies based on randomized trials, and that these observational studies, non-comparative studies, can really be very misleading. So Solidarity is one such international trial that was launched on March 18th by WHO and its partners, and compares 4 treatment options compared to the standard of care. That's standard of care in each of the participating hospital. And patients are randomized to 5 separate arms. And in just 2 months, which is really quite spectacular, more than 3,000 patients have been enrolled in 320 hospitals over 17 countries. I think you'll be aware of the different arms. It includes the remdesivir, lopinavir, ritonavir, the HIV drug, and another arm with lopinavir, ritonavir plus interferon, and then the chloroquine or hydroxychloroquine arm. And just a few days ago, the recruitment to this arm was suspended in light of the preliminary analyses. This arm is continuing in other countries, and there are some slight differences in the dosing used across these protocols, which is of relevance. In terms of vaccines, there's now a global coalition to really develop and evaluate a vaccine. There's more than 120 vaccines in development, others at more advanced stage, with a quest to really compress the time for development and access over time. And as part of this, there is this new COVID tools accelerator that's intended to really fast track the process, the development and production of a vaccine, production at scale, and equitable access. And again, there's been quite a lot in the literature about open licensing, the issue of patents that is still ongoing at the moment. Next slide, slide number 8. So this is the other important area of WHO, is this normative function leading on the policy and technical guidance. And for those of you who haven't visited the WHO website, it is really quite extraordinary. The huge number, more than 100 guidance documents, technical documents, scientific briefs in all multitude of areas across COVID that have been developed, and very much on using the criteria of evidence-based to support these recommendations. But this includes clinical management, laboratory surveillance, supplies and testing, and infection prevention and control. So I highlight this because this is a useful resource for those you in the community to be aware of a comprehensive resource with the supporting evidence base in your work with countries. Next slide. And I think the guidance continues, but 2 I wanted to highlight that I think are particularly relevant to those leading on a community response. That is of the operational guidance for maintaining essential health services during an outbreak, which we had at the time with the Ebola outbreak. That was developed. It was adapted early on in the COVID response, and now, just as of yesterday, has been launched again and updated. And I think the key point of this that you will all be very familiar with is that when health systems are overwhelmed, and we saw this during Ebola, we see that both direct mortality from the outbreak as well as the indirect mortality from vaccine preventable diseases, other treatable conditions, be it heart disease, strokes, kidney disease, cancer, do increase and can do so quite dramatically. And this has received a lot of attention recently in the low and middle income countries with some modeling work which showed the impact of disruption to TB, malaria, HIV services. And we've now had a similar one done for non-communicable disease showing this impact. And that if there was, in a worst case scenario, a 6-month interruption of ART, that could lead to 500,000 adult deaths over a 4-year period, really reversing all of the gains. And a similar story can be told for hepatitis. So what have we observed or heard about COVID impact on hepatitis services? Well, much of the information is largely based on anecdotal reports, but also through our WHO colleagues in 6 regions. So the challenges reported, obviously the situation in countries depends on the degree of lockdown, and what we're hearing, what was being reported a month ago is different from now as countries move out of different phases of lockdown. And the big focus has really been on continuity of ART. That's been the priority in so many countries. And in fairness, while hepatitis treatment interruptions are reported, it has been less of a problem and less of a concern about the continuity of the ART. We also have many reports of staff at the Ministries of Health and hospitals being repurposed to support COVID, suspension of routine clinics, and the testing, and particularly the testing and prevention efforts have been affected, as well as viral load testing for hepatitis C as personnel and machines get deployed for use in COVID, and the sample transport has often ceased. I think the key message from this new updated operational guidance for maintaining essential health services is the value of the mitigating approaches, if you will, and ensuring continued treatment with multi-month prescriptions. This has been now embedded in many countries, particularly in the context of HIV. But I should say, multi-month prescriptions it's a bit of a double-edged sword, that particularly where there are some fragile supply chain issues, that it can result in a stock out. So a differentiated approach is needed where you've got sufficient stock, let's say ARV stock. You can intensify your multi-month prescription. That had happened in Namibia and Malawi, but where the ARV stock or other stocks are precarious, to have a shorter multi-month prescription. I think the issue of postponing initiation for those not yet on treatment, it's less of a critical issue than for HIV. And then the all-important maintenance of harm reduction services and the use of extended and take-home doses of methadone and buprenorphine. But you'll be hearing more about that from Niklas and others later. We've also done our own survey for HIV, hepatitis, and STI at WHO with all our countries of impact on services, and clearly the ARV supply was of greatest concern, and there were 23 countries that were reporting up to a 40%, from 1 to 40% impact on ART provision, affecting around 200,000 persons on HIV. But this slide shows where the multi-month policy has been implemented for other areas, and we see it's been particularly implemented in the context of opiate substitution therapy, hepatitis B, as you would expect for a long-term therapy, less so for hepatitis C. Next slide. So this is the report from 53 countries that reported facing some form of disruption in services. And you see right at the top there, and this has been reported many times, that the biggest impact has been on HIV testing, particularly community-based testing. But we are also seeing, to a lesser extent, you see further down, 10 countries reporting impact on Hep B testing, 8 on Hep C, and then a fewer number reporting impact on treatment initiation. And then this next slide is just from colleagues in Punjab, Pakistan, just to give you a real life example of how things were impacted in the different stages of lockdown, pre-lockdown, compared with the early weeks of lockdown, and then as things moved out. So big, spectacular reduction initially, 82% reduction if you just look at the bars at the top of new registration and screening, 65% reduction in initiation of treatment, and then really very few clinics that were active. But what we've seen is a gradual recovery, so big impact, and very reassuringly now starting to return to pre-lockdown levels, but nowhere near there, quite there yet. Next slide. So leadership in the face of essential supply shortages. So people often don't associate WHO as being, responsible for driving the supply chain. But I think in response to what was, I think we all recognize, a bit of a wild west at one stage with PPE around the world, and each country working for them for their own interests and their own population. This was an attempt to establish some proper coordination of a supply chain, establishment of a task force working with World Food Programme that obviously has a lot of expertise in getting supplies, particularly food, to where it's needed. And again, underpinning this was really ensuring that supply chains, particularly to low and middle income countries, were being driven by the strategic and priority health needs and that gaps and supplies were being met. So this is a process of consolidating demand, consolidating and coordinating purchasing, and then streamlining the distribution. And this has been around tests, diagnostics, around PPE, and around clinical items, so ventilators, pulse oximeters, oxygen concentrators. And this has worked with many countries. So just my closing slides. So this is the WHO website, and I would encourage you to just take some time to browse around, because there's a lot of great stuff, some of it rather hidden, but and I think materials that would be really useful for you in the community. So I'm just going to highlight from this list and videos and other resources. So EpiWin is another output, and it has its own linked pod on the website. The address is up there, of really how to kind of repackage the science, and particularly the issue of managing infodemics. So this addresses a lot of the other issues on communicating to employers, workers, schools, faith-based organizations, youth organizations, and a lot of great risk communication products with videos, Mythbusters, infographics, Q&As, virtual frequently asked questions. So I think a good resource to look at. And finally, I think this has proved incredibly popular, the openwho.org, which is really a free open access learning platform for health emergencies. It was actually established in 2017, but now has 10 courses, and they're growing, related to COVID. It's had 2.5 million enrollments. It's translated into multiple languages. There's a whole translation unit connected with it, and covering a whole range of different areas. And the platform's first African language courses actually went live in Swahili, but also Amharic and Hausa is out there too. So I think that's a unique feature of this global platform. So I think I will stop there. It's a bit of a gallop through a range of WHO activities, but I hope this will be useful to you and to encourage you to use the website. Thank you.
Thank you so much, Philippa. And it's incredible to hear like the breadth and width of all the great things that WHO is doing and the incredible impact that you guys are having globally. So thank you so much for that. We are a little bit behind, so I'm just going to take one question though from our participants. So this is from Jack Wallace in Australia. He's asking, do you know if are there any restrictions on people living with viral hepatitis being involved in clinical trials? He said there could be good reasons for this, but I'm just interested to know. Do you have any insight on that?
Right, that is an excellent question. To my knowledge, being Hep B or Hep C positive is not a contraindication. But what I can do is check with my colleagues who are overseeing the Solidarity trial, because I have not seen a recent protocol and can check on that. I mean, as you're aware, the emerging data is somewhat reassuring for the majority of people with chronic hepatitis and chronic liver disease, as long as it's not advanced. But let me confirm that, and hopefully I'll have that in the chat by the end of the call.
Cary, I just wanted to add one thing which had come up in our NoHep webinar, because some of the medications, the immunomodulators, people just have to be aware that they potentially can reactivate hepatitis B. So that's something that if you're a patient or patient family, just to be aware of. And from obviously a lot of these studies do show that elevation of ALT can happen with hepatitis, but is not necessarily a flare as far as we know. But these are really great questions to think about for people who are, representing patients and thinking about patients. So thanks.
Yeah, no, thank you. And the Solidarity trial at the moment does not include an immunomodulatory component, but is likely to do going forward. And that may indeed have implications, as you say, for eligibility.
Thanks.
Thanks.
Excellent. Thank you both very much. So I'm going to move into our next presentation, which is for me, which is I'm going to talk about a survey that we've done recently. And I think a lot of what we've heard from members around the world echoes a lot of what you were talking about, Philippa. So I think it fits in really well. And I'd just like to say we have over 100 people on the webinar now, which is terrific. So, please do put your questions into the Q&A section, and we'll do our best to answer them, or to give you an opportunity to share your experiences. So as many of you know, we recently, and we are still running a survey around the impact of COVID-19 on civil society delivered hepatitis services and patients. Next slide, please. And our objectives were really just to measure the impact that COVID-19 has had on our members and civil society and their ability to serve their communities, to also measure the impact the crisis is having on people living with viral hepatitis and their ability to access treatment and services, and also to look at the various factors of the crisis and see, which ones were affecting it more or less. And finally, it was to gather best practice for dissemination and to inform our work as a network of civil society organizations. Next slide, please. So it was a very simple, 13 question self-completion online questionnaire. There were some multiple choice questions, and there were also several free text questions where you could express yourself the way you wanted to. And we advertised it on social media, through our email lists, and also several of our stakeholders very kindly helped share it as well. So up until the middle of May, we had 128 responses from 32 countries. And we had a really great response from the United States. 62 of those respondents were from the United States, mostly because it was shared through several networks there. But we also had very good multiple response rates from Nigeria and India, and had a total of 32 countries from all around the world. So we got a very good spread. But because we do have more respondents from the United States, in the slides that are coming up, I've separated actually the United States from the rest of the respondents, so we can just kind of see what's similar, maybe what's different, and so it doesn't have an undue influence on the numbers. Next slide, please. So the big question, of course, was, are people living with viral hepatitis able to, who are on treatment, able to access the medication? And as you can see, most people said they were, but a very worrying minority, globally, over 35%, or just about 35% said that they weren't able to access the medication. And obviously, this is extremely worrying. And significantly less than that said that in America said that that people were having problems accessing medication. Next slide, please. And when we looked at this globally, across 4 different areas. So these are the 4 countries that we had the largest sample sizes. As you can see, respondents from India and Nigeria were more likely to say that people were having problems or couldn't access medication. The United Kingdom, which of course has a national health system, universal health coverage, no one actually responded that they thought people were having problems accessing medication. And in the United States, where there's kind of a mixed healthcare system, some people did say that they felt that people were having problems accessing the medications. So you can see there's a definite difference depending on where you are in the world. Next slide, please. So then we asked for what the reasons were, and this is data from the U.S. And for the U.S., I think the main reason that people actually listed were the travel restrictions, that people weren't able to travel in to get their medications to the hospital. So a lot about what Philippa was talking about multi-month prescriptions, actually obviously would have a big impact here. But there was also, the second highest was that people were actually avoiding going to health facilities because of COVID. And this is a theme that comes up more, that this is actually a really big issue. And also, that health services were either closed or were refocused on COVID-19. So next slide, please. So, sorry, actually that was the global numbers, excuse me. So in the USA, people avoiding health facilities was actually the greatest reason why people said that they were having problems accessing treatment. So followed by the refocusing of services and services being closed. Next slide, please. And also in the US, when we asked whether there was adequate information about COVID-19 provided to people living with viral hepatitis, as you can see, just only about 24% of respondents in the US felt that there was adequate information being provided for people living with viral hepatitis. Next slide, please. And then when you look globally, although it's a slightly higher percentage who said yes, it's still almost 2/3 were either said no or were unsure. And we noticed this quite early on in the crisis, that there was a real lack of information relating to COVID-19 and people living with viral hepatitis, which is why at the Alliance we created an online information hub where we've kind of collated all the information that's available globally from different sources and put it all in one place. So there was a place where people could find all the best information from around the world on viral hepatitis and COVID-19 for people who are living with viral hepatitis, but also for our communities that we serve. So also for prisoners and for people who inject drugs and migrants and other groups. So please do check out that webpage, worldhepatitis.org/COVID-19, if you would like some additional information. And if you have any information or if you produced any information that you think should be included, please let us know and we'll be very happy to include it. Next slide, please. So we then asked, have services provided by your organization been affected by the outbreak? And unsurprisingly, 95%, even more of the American sample have said they've been affected because of, COVID has affected, I think, everyone in so many ways. Next slide, please. When we asked in the free text responses why they thought their services were affected, you can see globally that people were avoiding going to testing facilities was the #1 reason they felt that was affecting their services. More than the services being canceled, the services being shut, even more than travel restrictions, stay-at-home orders or lockdowns. That this was the biggest reason why people weren't turning up. In the United States, that was also a big issue, but also that actually the testing facilities were closed, indicating that perhaps in the United States, maybe more community testing and facilities were closed down. Next slide, please. So I think just looking at this very kind of preliminary data, and we haven't even really begun to analyze this properly or completely, that the COVID crisis has definitely impacted the ability of our members and civil society organizations to deliver services. It's definitely impacted, but in varying ways around the world, patients' ability to access treatment. And the reluctance of people to access hepatitis services can be, because of fear of COVID, is often a greater barrier than limitations on movement or even the closure of services. And most respondents did not agree that adequate information about COVID had been provided in their country for people living with viral hepatitis. So these are all really big, huge challenges that we know that you as WHA members have taken up these challenges and really evolved in order to reach these challenges. So that's all for me. So that's just kind of the general overview. And now I'd like to just kind of go straight into hearing from you, the members, about what you are doing out there and have a discussion and share some experiences about how you're rising to the challenges of the COVID-19 crisis. So our first section of this is going to be about the redeployment of services, how our members have redeployed their services in the light of COVID. And again, the Q&A box is open if you would like to ask any questions. I think our panelists will be available online to ask them questions specifically, or if you want to share your experiences. So we're going to have 2 videos. The first video is from Surendra Kumar from RAN Association in India. So let's play Surendra's video, please.
Hi everyone, I am Kumar, founder of Run Foundation. As you know that Run Foundation works for the awareness, prevention and control of viral hepatitis. So, our focus is completely on the prevention of the COVID-19, that we are working in the community, we are trying to educate, we are educating the community about the COVID-19 infection. And as an organization, it's a very critical time for us to serve the needy people, that as of now, where most of the population is under lockdown, that so many vulnerable groups need some essential services like food, rations, sanitation material. So Run Foundation is continuously in touch with that community who needs essential services, that we are continuously providing just like sanitary napkins, dry ration to the community. Hi everyone.
We work in the community.
Oh, sorry.
We work in the community as a non-profit. We go out there and work in the community. And the funny thing is that even before the government called for a lockdown, we started with the lockdown policy because we run a low-income health post in a blighted community. And we just found that it would be too risky keeping the health post open with this outbreak, and so we did our lockdown even much earlier than the government pronounced the lockdown. So it's not been easy, but within the Live Well initiative, we've responded by deploying a team. We have a team on the front line, and we have found that Africa being what it is, the whole world has been ravaged by this big major pestilence. And Africa being a bit disadvantaged because Africa is not very rich with resources financially. And so we found that we just need to take the bull by the horn and devise a means of making a way for Africa, even in the midst of this pestilence.
Brilliant, thank you. So as you can see, that second video is from Busy Bright from the Live Well Initiative and Women in Hepatitis from Nigeria. And I'd like to welcome Busy and Surrender to the panel. Welcome to both of you.
Hi, I'm audible.
Brilliant, thank you. So if you have any questions, hi Busy, hi Surrender. Great to see you. So,
yeah, thank you. Happy to be here. Thank you.
Thank you. So if you have any questions for either of them, please put them in the Q&A box. But I would just like to just kind of kick off that in both of your stories, we heard about how you are working with your community to spread information and awareness. But to what extent do you think community organizations have been used by your countries, like officially used by your governments or your local authorities in the COVID response? Have they asked you officially to become part of it? Maybe Busy, do you want to start?
Yes, thank you, Cary. And hello again, everyone. It's a privilege and pleasure to be here today. I would say that because of the fact that preparedness for COVID-19 involves a lot of logistics and so on, the CSO voice is not really largely involved so far in the country. The government has deployed a national COVID think tank where you have a lot of health professionals discussing and brainstorming on COVID. I have the privilege of being in the National COVID think tank. I was invited, so I would say they have actually tried to bring in a few voices. But at the point of action, the government has a PTF, it's a special task force, a national task force on COVID. I'm not really sure that the civil society voice is there. It's a lot of financial experts and technocrats that have been put there. So I'm not really sure that the CSO voice is there. And the major challenge with the CSOs is that you need PPEs to go out into the communities and to make interventions. However, I must be very fair with the local government, that's the government at the community level. Of recent, they have deployed, it's very recent, some 2-3 weeks ago, they have deployed now teams of the local government officials, at least in Lagos, to work with CSOs in communities and go in there, although it is largely a government-controlled thing. So I would say the CSO voice is not actively involved yet, but is passively involved. However, from our own organization, in Live Well Initiative, we have come around working out something that would still work and make our voices heard, even without being invited. We have kind of deployed teams because the government called for volunteers. So we have healthcare professionals at the front line working in isolation centers. So we have found ourselves being involved at that level. We are also running telehealth services, and we are working, although not being remunerated, we are working by linking patients out there to the government COVID and non-COVID centers. And some of our own health practitioners are also giving free counseling online. So we have nutritionists. We deployed 2 nutritionists, 2 pharmacists, 2 doctors, and 2 nurses. So we have an 8-man team with 2 supervisors doing a national telehealth service. It's not remunerated, but we're doing that. So I'm just trying to encourage CSOs. There's some things you can do even if you've not been called in and you've not been given money. And then we designed treatment protocols for COVID-19 in Africa. The protocols are replicable and usable, scalable everywhere in the world. But I use the word Africa because we designed them for low-income settings where there's little income and there's little affordability. These are that can be used everywhere. And we have quite a number of health institutions all over the country already using these protocols for the treatment of COVID with very good response. It was the simple chloroquine protocol with very safe doses being used by us. And I'll be happy to discuss it because the WHO trials are good, but their doses are high. With very low doses, when given with zinc, chloroquine will achieve potentiated effect of a higher dose, and it's a much safer option. I don't know if I've used up my time, but...
No, that's great. Thank you very much. And it's great to hear that the government there, the local authorities are starting to include civil society. I mean, I was on a call with that, sorry. I was included in a call. Thank you very much. I was included in a group call with Tedros from WHO on Tuesday, and he expressed his commitment to increasing the role of CSOs in the COVID response. So I think we're going to see a lot more from the top down, and countries being encouraged to use the talents and skills of CSOs in this response, because just like we said at the beginning, the groups that are disproportionately affected by COVID are very often the same ones which are disproportionately affected by viral hepatitis. So we are there already with these communities. So it only makes sense that we are the ones that helps reach them in this crisis. Surrender.
Thank you very much.
Thank you. What's the experience like where you are about civil societies being included officially in the response?
Hi, first of all, thanks a lot for including me in this town hall meeting. All of you know that I'm a hepatitis B positive and I'm working for the awareness prevention of this disease from last 3 years in India. And we know very well that this is the very high time that it's an international emergency of COVID-19 and most of the countries are facing lockdown and maximum population is inside the door. And for us, it's very difficult to organize our No Hep campaign. All of you know that in India, last year we have launched No Have Delhi campaign. In this campaign, we have included around 20,000 young students in the community, like in the schools and educational institutions. Just because of the COVID-19 situation, we are not able to conduct that kind of big project like No Have Delhi. And we are planning this year, to make it more impactable, to include around 30 to 40,000 more young students under No Have Delhi campaign. But as of now, that we all know that just because of the COVID-19, first of all, we have to fight this infection as of now. And the World Health Organization set a goal for the elimination of viral hepatitis until 2030. This means that the number of newly infected persons and the related mortality should be decreased by 90%. As per my estimate, the elimination program focuses on different parts such as testing, treatment, immunization against hepatitis B virus. But just because of the COVID-19 situations, to keep in mind that the social distancing and to follow the preventive measure, we are not able to organize mass testing. And in fact, I would say that the immunization of universal immunization program in India is also affected by the lockdown. That we are here in India around 2 months, we are inside the door and no other activities are happening on the ground. That the infant and the 0 to 5 years children are not getting immunization on time. And we know very well that firstly, we have to face this COVID-19 situation. We have to come out from the COVID-19 infection. Then we can resume our services like No Have Delhi campaign. And in fact, we are planning to move out in the villages this time. That in Indian community, more than 70% population reside in villages. And we have to focus on preventive steps inside the villages, that more of the but we have to increase the birth dose immunization of hepatitis B. So my experience during the COVID-19 situation is that hepatitis patients are facing so many problems. Just like I spoke to a few of my friends who are hepatitis B infected, they are not getting their medicine on time just because of the lockdown, and transportation services is not effective in the countries. So they are suffering without medicines. And I spoke to one or two of my friends, and I was trying to provide them the medications via courier. And in fact, I was planning to travel 150 or 200 kilometers just to give the medicines. So this is the situation over here in India. Okay, but the overall experience during this 65 days, that the most of the population is, they need some essential services, like they need food, they need sanitary napkins, they need some hygiene kits. So what we have done, we have distributed food ration, we have distributed so many sanitary napkins, and we have distributed soap and sanitizer. And we educated around in 3 states. We are working in the 3 states, and we educated most of the population how to prevent COVID-19, first of all. Okay, so our focus is completely to come out from this emergency situation, and hopefully very soon we are going to resume all our project under NOHAP. And I wish that all the situation, everything get well soon, and we can start our all the project as soon as possible. Thank you.
Brilliant. Thank you so much. And it's so inspiring to hear from both of you the kind of wide-ranging response that you're providing your communities around COVID, because it's not just about, the specific disease, but it's also the hardship that they're going through, economically, or, being able to access food and services, or not being able to earn money because of the lockdowns. I mean, we had a question in the chat for you, Surinder, about what you think the main challenge is for Hep patients in India. And I think you kind of very elegantly talked about, it's not just It's not just one thing, it's many things, right? That's a challenge for Hep patients at this time.
Okay, I personally feel that I have to go to the doctor for the fibroscan, and I'm talking myself that I need a regular checkup of like my liver screening, my liver profile. So I'm not able to get a consultation. I'm not able to get a appointment of a doctor in the regular hospital. So all the hospital facilities are converted into COVID-19 facilities. So we are waiting to get the situation normal so that we can regular consult about our hepatitis B infection, about our medications, about regular tested like our LFT and I would like to tell you that not only me, but my mother and my brother is also a hepatitis B positive, and 3 members in my family are suffering from hepatitis B. And we all are on medications, and every 6 months or every 5 to 6 months, we have to go to hospital for the regular checkup. And during this 2 months, we are not able to go outside our home. And my mother, last month, my mother was out of medicine. Then somehow I arranged the medicines. And like in India, we are facing a problem in the medications. Medicines are not available in the most of the part.
Great, thank you. And we just had one more comment. It was more of a comment, but maybe Busy, you'd like to sort of add to this from Dr. Clement in Nigeria. And he said that, I think enough information is being provided on COVID-19, but the challenge is how people utilize this information to make a positive change. Some still deny the existence of the infection. Some will not follow all listed precautions like physical distancing, among others. I think we will need to sustain these efforts. People do not change the behaviors overnight. Persistence is key. So do you have, please, Busy, go on.
Yes, thank you, Cary. That is very true because people like to see things happen. They want to see the evidence. It's like people imagine that they just see people dropping dead on the streets. And so the mindset, there's still a few people who believe that there is nothing like COVID. I think so far the curve has been reasonably flattened. So it makes people really believe that it's not really out there. But people do need to change their attitudes. We have found out that with social distancing and hand washing and teaching people personal hygiene, how to sneeze into the cough and so on, it is really helping. I believe it's helping with the figures. And there was a part of the country where we had even though those people were suspect or it's believed that it was because of the attitude. And now that the government deployed a lot of CSOs and so on into that space, the attitude has been changing. So it's true what Dr. Clement has said about the attitude, but I believe that if CSOs are deployed more, that attitude will change faster. And so maybe Dr. Clement, I appeal to you, maybe the Federal Ministry of Health also needs to engage the CSOs, and that problem will be very well taken care of. The CSOs can do a lot because we are the ones that go into the communities, and the local government is already working with CSOs. So the federal government can also do that. It will add much more value and also help to improve the practices and attitudes of the people, because many more CSOs will be able to go into many more communities. Thank you.
Brilliant, thank you. And thank you both very much for being part of this. I'm now gonna move on. That way we could talk about this for much longer, but we have other things to talk about. So thank you both very much.
Thank you.
Thank you. And now we're going to move into our next interactive session, which is looking at how the current crisis, the impact it has on the communities we serve. And we're going to start with a video from Matt Bond from Halifax in Canada. And it's about how COVID-19, the pandemic is having an impact on people who access harm reduction services, a population we know disproportionately affected by both hepatitis and COVID-19. So let's play Matt's video.
A lot of the services that were aimed at kind of, serving this community have been either extremely reduced or closed. So how do we support them in the middle of a pandemic and an overdose crisis? We need to still be able to provide support to people in various forms, where we're encouraging anybody who is using alone to call a friend, call somebody they trust, and let them know your address, so that they can call EMS in case you overdose. We have a biometric contactless secure automated kiosk in the downtown east side of Vancouver, where people go to get their safe supply of drug. It's the first in the world. They put their palm up. They don't even have to touch anything to get their pills except for grabbing the pills. But it's a way to minimize contact with minimize unnecessary contact. And it's going to be interesting to see how these machines get rolled out. They are meant for a safe supply, but there's some possibility that they could provide, hepatitis C medication in a less stigmatized and a more autonomous way for the individual, which would, be a lot more person-centered for someone to use that is not comfortable talking to a pharmacist about hepatitis C medication.
That's great, thank you. And we're very lucky to have Matt join us on the panel today. Hi, Matt.
Hey, Cary, how's it going?
Very well, thank you, welcome. We also have Rachel Halford from the Hepatitis C Trust in London.
Hi, Cary.
And Nonso Maduka from the Bensler Development Foundation in Nigeria. Welcome, Nonso.
Thank you.
But before that,
hello.
Yep, hi. But before that, we're going to have a short presentation by, hi Nonso. We're going to have a short presentation by Niklas Luhmann, who's also from the Global HIV, Hepatitis, and Sexually Transmitted Infection Program at WHO headquarters in Geneva. So Niklas, please, the floor is yours.
Hello, everyone. Good afternoon, good morning, and good evening. Maybe, Cary, can you hear me? Yes, okay. So thanks so much for having me. I will try to be short because, as you said, interaction is maybe the most important. Here, it's really great that there is a slot for this very important topic, and I see the colleagues that are on as well. I wanted to say as well that I'm really happy to hear your interesting survey results and to hear from so many different community organizations in the hepatitis response. It's a pleasure to be on here. So I really wanted to just give a very short couple of slides around WHO guidance and in the area of vulnerable populations and harm reduction. So next slide, please. Maybe this very, very short, just wanted to highlight again why some of the key populations, and for example, people who inject drugs, people who use drugs, or homeless people may be in at a higher risk of infection with SARS-CoV-2 or developing COVID-19. So this is not completely exhaustive, but some of this could be related to the fact that some of those populations have higher or additional comorbidities, that there is sometimes a reduced ability to apply measures of confinement and social distancing due to life conditions and other points, and generally as well reduced access to health services. Next slide, please. Go again, because there's half of this, or the title. Okay, then come back, the title is missing. So it's go back to this one. Yeah, there's just the title missing. I'm sorry for that. Basically, this is one of the two core slides. It relates to the two documents that have as well been shortly shown and presented by my colleague, Philippa Easterbrook. So these two documents are really core in our area. One is focusing, the upper one, done with UNICEF, on the community-based and prevention services and their continuity, and the second one more on the clinical and chronic care. I think we have been not challenged, but asked on many webinars and discussions with other civils or with you and other civil society groups to really be clear on what WHO would consider essential health services, because this obviously is a core point here in countries where one has to reprioritize during that crisis to some extent, because maybe not all of those services or not all services in prevention and care can be continued. So both of these documents state some general principles, and then in the annex you will find what is specific to HIV and hepatitis, and they state, when we're talking about people who inject drugs quite clearly and harm reduction, that these prevention services, needle and syringe programs and opiate substitution therapy, but as well condom programs are essential, should be considered essential services. Then, so that's the one in blue. In the wording in black, you see more detailed recommendations or practice around giving information to patients. Patient-centered outreach might sometimes be prioritized over facility-based services if those can be organized better and allow for better social distancing. But I think most experiences from countries have shown that some level of facility-based services as well for harm reduction needs to be continued, and then apply some of those measures. We have heard already about longer term commodities and supplies that can be provided in larger quantities. It states as well that some of the prevention interventions that relate to larger groupings should be discontinued or postponed. Next slide. So one very important area that I just wanted to focus shortly on is the continuity of opiate substitution therapy with methadone, buprenorphine or others. I mean, here we're really in a program area that should be considered absolutely essential, because any interruption or delay or change can have a very direct and strong impact on mortality and morbidity of the clients. So really countries should make quite a strong effort to continue those services. We've seen in many countries quite a lot quick decisions around increased take-home doses for methadone or buprenorphine with longer periods, and for clients who have not profited yet from that dispositif. So that is a very interesting area where countries have been pragmatic, including countries which haven't had a strong policy yet in this area. So we're as well working with UNODC to potentially evaluate some of those examples or describe them to see if they can be to some extent be continued after the crisis or the lockdown is eased. Some of those examples have shown interesting adaptation of psychosocial support through web-based services or phones, for example. Another thing that I wanted to mention, it came up from a lot of implementers, is that actually maybe contrary to some, from what we may think, actually more people have presented in many countries to OST services, because the supply or the capacity to even buy drugs might have changed, because many people depend on informal work, and so many people present with involuntary withdrawal and should be considered within the capacity definitely for short-term or long-term induction of OST. And I think the other things have been said already by colleagues. So next slide. So that was the example for Morocco. Here as well, the layout changed a little bit, sorry for that. But it is basically, as I just said, one of those countries. Others include Bangladesh, India, Myanmar, and many others, who have very quickly taken a very pragmatic approach, at least for their, how they have seen or looked into OST and harm reduction before. So 2 weeks take home those in Morocco now, and the 7 NGOs here, civil society colleagues that provide those services, online and phone support, psychosocial support, some home delivery, collaboration between MOH clinics and communities, and as well needle and syringe and naloxone programming have been adapted during this time. Next slide. So this gives you, again, the links to those 2 documents that we have mentioned and the overall web page. You can find it as well in the other WHO presentation. Maybe just to say at the end, I mean, this is not to say that there's no problems or reported challenges in harm reduction continuity. On the contrary, many countries have had quite a lot of challenges in continuing these important prevention and care services. And it is a very often stigmatized and criminalized population. So this stigma is sometimes or often augmented by this type of crisis. And so I didn't show that data, but I think it's important to just show what really WHO has done in terms of guidance. And we support a lot of countries in Asia, Eastern Europe, and other regions to work on the most evidence-based and pragmatic change and adaptation of those services. Thanks.
Brilliant. Thanks, Niklas. And this is such useful and valuable resources, and I hope people have the opportunity to check them out. So if you have any questions for Niklas, please do put it in the Q&A box or any of our panelists. But now I think I'm going to go back to our other panelists and just kind of get a feeling from them about and hear from them about how COVID is impacting people who inject drugs in their country and what they're doing to address that. So maybe Rachel, would you like to go first?
Yeah, thank you for inviting me. I suppose in the UK, it's been, you know, the same with most countries, that the face-to-face contact has been really limited. So most of the drug services, they were working virtually, with staff working virtually at home, with a skeleton staff just for new assessments, because we've seen a huge spike in the numbers of people arriving at drug services wanting harm minimization, harm min services. Right from the beginning, there was a really, we had a big shortage of drugs on the street from the beginning, very quickly, which meant more people were turning up. In terms of needle exchanges, I'm not really sure what's going on with needle exchanges. I think that there are a few, but there's huge concern, because obviously one of the dangers is no needle exchange, then you run a risk of transmission, an increased transmission. And I interestingly had a conversation with somebody who was in New York last week, and he was saying that one of the biggest concerns, because their services had been so reduced, was that there were so many people going back to illicit drugs that in fact the transmission rate would probably increase quite significantly. Alongside that, for us as an organisation, so we're a patient organisation, we have lots of peers that work for us. What we've managed to do is we have a majority of the patients we work with and our clients are people who inject drugs or people who come from the most marginalised edges of society, homeless or those in hostels. So we have, as soon as shutdown happened, we obviously as an organisation, we had to find PPE and etc. But quite a few of our staff carried on working. So we delivered packages of food to patients who couldn't get out. We spent a lot of time delivering medication because unfortunately, unlike Canada, we don't have any options like a drop-off. The medication has to come through the pharmacy. But we managed to be the go-between and go and pick up the medication and drop it off for people who were on treatment. More interestingly, I mean, one of the bigger initiatives that we've had here is that we have a lot of people, homeless people, who sleep rough on the streets. So for example, in London, it's probably about 2,000, just under 2,000 people. And what happened was that there was an initiative whereby everybody who was on the streets was moved into hotels, so hostels or hotels. So we all of a sudden had this opportunity. Well, the most important thing is that the people who were living in those conditions actually had an opportunity to have somewhere safe to stay. But secondly, alongside that, it opened up this massive opportunity to provide them with to address all their needs, whether that's mental health, sexual health, but additionally, getting tested for BBVs, hepatitis C included. So for example, in London, a fantastic team has come together of clinicians, nurses, and we go and target the hotels or the hostels. The peers join them and we actually test everybody. So it's been within all of this chaos and difficulty, we've managed to find some opportunities to reach people that we wouldn't necessarily have been able to reach before. It's difficult because obviously we have to consider PPE equipment, you know, and as an organisation, we have to make sure our staff are safe. But it's just meant that we're having to learn to work in a really different way. And what's happening here is these hostels and hotels have opened up across the country. So we will, for a moment, be able to reach people that we have very rarely get an opportunity to reach.
Brilliant. Thank you. Thank you so much. Nonso, would you like to give us your impressions from Nigeria?
Yeah, I will. I would. Good afternoon, everybody. Yeah, I like to appreciate this privilege of having to come on and share our experience in Nigeria. Unlike some other clients, in Nigeria, harm reduction is just taking off. We were actually meant to be on a pilot stage nationally as per the government involvement. However, the COVID cut things short. So most of the things we, the community-based or CSOs are doing, we do underground. So full-blown harm reduction services like OST is not really in place. But for the CSOs, we tend to do things like NSP, needle syringe exchange programs. Within the COVID, it's been very difficult because you are not just dealing with the issue of COVID, you are dealing with the issue of the legal status of drug use in the country. Let me just give an example. Where I stay, the state I am in Enugu, just about a month before the COVID, the governor of the state himself led the police force to raid some of the bunks that drug users who are homeless normally stay. And so you can get the complication where almost every 20 minutes, police people are moving around bunks, trying to see who they're going to arrest. However, my advantage in my organization working is that being a pharmacist, it has also helped me get access to move around where most people are not able to move. And so within this period, we did some things because in Nigeria, harm reduction goes beyond, it goes beyond the issue of OST, it goes beyond the issue of needle syringe exchange. It goes into issues of homelessness. It goes into issue of people being able to feed. It goes into issue being able to provide sanitary kits for themselves. So my organization, what we just did within this period was to map out about 4 bunks. There's so many bunks. We mapped about 4 bunks where we visited, we sensitized them, because that's another issue. Because of the nature of drug users, they enjoy communal living. They mix together a lot. Unfortunately, in the COVID measures, the government have not actually considered this group of people. So for most of them, they're actually lost about COVID. They really don't know your prevention measures. So what we did was first design a pamphlet and IEC material that we used to visit them. And when we got there, first we took our time to talk about COVID. You get the general prevention, the social distancing, why you need to wear masks. You get, after that, we now went into issues about drug-specific issues that increases your risk, like sharing drugs, like sharing paraphernalias. You get the issues of high contamination of drugs. That's another issue that we experience in this period because the stocks are running out. Some of the dealers, the dealers are mixing a lot of rubbish into the drugs they are giving these people. And so we find a situation that we have to talk to them. Please don't try because the stocks are running out. You want to, oh, you had there's a new dealer there that is selling. Please keep to your original.
Oh, I think we might have
Hello?
lost. Oh, yes.
Hello, hello?
Yeah, we're just having a little bit of audio problems now. So maybe you could just wrap up, maybe. Sorry about that.
Okay. Yeah, to just deal with the issues of managing their issues of withdrawal and issues of overdose. We distributed some vitamins. We asked them to keep taking these on daily basis. to require talk to them about the quantity of water they need to be taking, because people that take stimulants always having issues with dehydration and the quantity of water they need to be taking. So we visited about 4 different bunks within my state, which is Enugu, talking with people that were injecting drugs and then people that were using drugs. Yeah.
That's excellent. Well, thank you so much. And it's so heartening to see this kind of real patient, person-centered approach to the work that all of you do with this very important community. So finally, Matt, I mean, I think it's incredible to hear like the innovations that you guys do in Canada. It's really like inspiring. So what's your experience been like working with these communities on the ground?
Well, you know, I think COVID-19 has shown a light on the health disparities that people who use drugs in our community have been facing for quite some time. And we talk a lot about a pandemic, but people who use drugs are facing a syndemic of health issues of COVID-19, increasing overdoses, homelessness, mass incarceration, and, you know, HIV and hepatitis C. We have a lot of like harm reduction services that had to reduce their capacities, which has led to another wave of this overdose epidemic that we have been in. But, you know, drug users have really kind of innovatively came up with harm reduction measures such as, you know, drug use spotting. So if it's through Zoom where, you know, one drug user uses and the other drug user has their address to call EMS in case there's unresponsiveness. A lot of the harm reduction services have reduced, especially at the time of the video, but have since kind of increased their, well, they're starting to slowly increase their service and kind of deal with like trying to figure out how to manage and provide service delivery during COVID-19. And just, I guess, the one thing I'll say to wrap up, very much like London, like Rachel said, with the homeless shelters, we've seen a lot of kind of action and resources and money go into temporarily housing people experiencing with homelessness. And, you know, I think that's something that hotels should have to take on from now on. But already we're starting to see that a lot of these COVID-19 pop-up shelters in areas where we haven't seen cases or, you know, cases have been really low for quite some time, you know, the funding is getting pulled from them and they'll be back into shelters and with the fall coming up and a potential second wave of COVID-19 is going to happen all over again. And people who use drugs will bear the brunt of another deadly illness such as HIV and hepatitis C. So I think we have to really, you know, think progressively and look to sustainable measures of how do we treat people who use drugs with health equity and provide them adequate care.
Excellent, thank you. And thanks to all our panelists. I'm afraid I'm going to have to move us on now, but if you have any questions for Niklas or any of the other panelists, do please put it into the Q&A function and then we'll pass those on and make sure those are answered. So thank you, all of you. Thank you very much. So we're just going to move on to our final section. Thanks. Which is about service adaptation. And we're going to have 2 videos. The first one's from Arafat from the Great Lakes Peace Center in Uganda. And the second one is from Zunaid, who's from the National Liver Foundation of Bangladesh. So let's play the videos.
I'm called Muhammad Arafat. I work with the Great Lakes Peace Center and the Bwera General Hospital, where we have a vast number of the elderly people who get refills for hypertension and diabetes. And under this COVID-19, we at Great Lakes Peace Center and Bwera General Hospital, what we are doing is to ensure that these elderly people are not able to access the hospital. We do personal delivery of refills for the drugs. And we do it through the committee that pretends over their welfare in the hospital. The chairperson profiles the names of the elderly who need the services, and I'm called upon with my colleagues who are volunteers. We walk on foot, or we ride bicycles, or we use motorcycles for those who stay very, very far. So basically, this is what we are doing under this COVID-19, and because the elderly people are the people who we definitely stay with, and we cannot afford to see them starve or not to get their drugs when you're there. Also, we deliver those who are known to us who are on medication for hepatitis B, so that they can get their refills.
Our National Liver Foundation of Bangladesh is being closed from mid-March due to nationwide lockdown. We are doing awareness on COVID-19 pandemic and liver disease in Bangla and English, both language, in our social media. We regularly posted awareness messages and articles. Our Secretary General, Professor Muhammad Ali, gave an interview in National News Agency of Bangladesh, BSS, which is widely circulated. And he wrote an article in the National News Daily, which is viral in our social media. And I'd like to thank World Hepatitis Alliance for their support and the resources they give us about COVID-19 and liver disease.
Excellent, thank you. So I'm very pleased and honored to be joined by Arafat and Professor Muhammad Ali from the National Liver Foundation of Bangladesh on the panel. Welcome, both of you. So maybe we could start with Professor Ali. What has been the biggest challenge that you've faced in Bangladesh around delivering services at this time?
Thanks, Cary, for inviting for this panel. And a lot of problem nowadays going on regarding this viral hepatitis issue during this COVID pandemic. As Junaid has already highlighted, we have given interview publications in the national dailies and in our social media, and we are very much viral about creating the awareness, particularly related to the COVID-19 and our all liver disease patients. But everywhere it is the same, that it is very difficult to reach them people and continue our this awareness building activities. And another thing which is going on, this drug trafficking, transfer availability with the drug to these patients. And what we are doing, we are instructing our people, so enroll patients, all patients, to get their drugs, continue their drugs from the nearby supplies. And we conduct free hepatitis B and C treatment in the Zakat Fund. And right now, we have got the 149 patients receiving free treatment from the Zakat Fund, hepatitis B and C. We are providing their drugs by courier services, and we are giving them all the instructions, other things. When the lockdown will be over, we'll go on again back to our activities, and we reinforce these activities with the social medias and that is the teleconferences, and we'll look for this. That is this main problem is disadvantaged, underprivileged communities will reach through our. We have got we have got a network in the Bangladesh as NOHET network, and we have got the volunteers throughout the nation. We'll engage them and to reach this underprivileged communities and disadvantaged communities for their awareness building, for ability of the drugs, that testing and other things. By just in this COVID-19, as long it is not controlled. Main concern what I like to highlight the community, particularly all the members of the WHO, that in this COVID-19 pandemic situation, everything in this lockdown, and all the government, not only Bangladesh, every government is engaged with the management of the COVID-19 pandemic with the high mortality and morbidity, and particularly that is this lockdown causing financial breakdown, economic breakdown. In this situation, we cannot approach the government right now for continuation of this viral hepatitis awareness campaign and other things. At that time, what I am thinking that our about our set target of elimination 2030 is in jeopardy, because right now I cannot approach the government to start a viral hepatitis awareness building program or financing for the program and other things. So I'm thinking that that our target of 2030 elimination is really in a setback. What I am thinking that yes, whatever facilities available, our format will continue with maintaining the social distancing and other properties. Because another thing, the safety of the peoples working in the organization is the first. If they become sick, suppose I have got a lot of staffs and everybody becomes my consultant, my laboratory technician, my other personnel, sonographers and others get sick with the COVID, then the institution will be ruined. So we must have to see first the safety of our people of our organization, then we'll continue our programs as far as possible. Second thing is everybody must have to think about this, about the target of our elimination target 2030. I think globally it is in the jeopardy because every government is involved with the COVID management and the economic hardship management. So what my suggestion that we'll continue our efforts as far as possible and we'll grossly reinforce our activities when the COVID-19 pandemic will be over, so that we can get back our really back to the track again to reach the 2030 elimination. And I am again thankful to the WHO for sharing the resources of the COVID-19 patients living with viral hepatitis, and we are continuously working for the people of viral hepatitis, whatever the things come, and we'll continue to this. Thank you, everybody.
Thank you so much, Professor Ali. Those are such important points, and it's, you know, it's a very, you know, we're 10 years to go until 2030. So what impact will the COVID have on our ability to make those targets? And how do we get governments, you know, not to you know, to remember the commitments that they made in 2016 for hepatitis elimination. So as WHA, there's a few things coming up that people can look out for on that front. We're currently drafting a community letter that organizations and individuals will have an opportunity to sign to be released on World Hepatitis Day, doing exactly that, calling on governments and ministries to honor the commitments they made for the 2030 elimination with 10 years to go. And also, of course, we're planning the World Hepatitis Summit for 2021. And that's going to really focus on, you know, how does hepatitis elimination fit into the evolving health systems that were evolving anyway, and now with COVID-19 are evolving even quicker and maybe in different ways. So those are all very important points. So Arafat, lovely, great to see you. So can you tell us about some of the big challenges that you guys are facing at the moment in Uganda and how you're overcoming them?
Okay, thank you very much, Cary James. I'm profoundly honored and exceedingly humbled to be here for this call, of course, to highlight some of the efforts we are trying to do, particularly at Great Lakes Peace Center. One is that we have been able to profile the groups of people who need the refill, especially now that we are in the lockdown and people are not able to move from the places they are in because our transport system was completely curtailed. It's just a few authorized government vehicles and the implementing partners who are able to move. So this really made, you know, most of the people who suffer from viral hepatitis not be able to come along for the services at the hospital. Let it be refill, let it be counseling, let it be information sharing, let it be vaccination, let it be, you know, seeking any service in viral hepatitis services. Most of the challenges which I can really talk about is definitely we as CSOs, we have not been able to have means of transport. You know, like our places has a terrain of mountains, and most of the other people who suffer from viral hepatitis stay far away from the health point delivery points. The other thing, like my colleague had already alluded to, the fact that we don't also have protective, personal protective gears. As you want to go to the communities and interact with the patients, you want to also have PPEs. The other thing is that recently, if you have been following the world news, is that Kasese, particularly Rwenzori region, has been hit with floods, with torrential rains, which are exacerbated by the glacier melting at the mountain Rwenzori. So we had floods coming in. Also, we live along the borders of Democratic Republic of Congo. So we continue having threats of Ebola, and then also other infections, not missing out on measles. And then also we have been having challenges of stockouts of logistics, particularly in the medicine. We have been having challenges along that. But importantly, we as the CSO, what have we been able to prescribe solutions to what has been affecting the viral hepatitis community is one is that we have a group of volunteers who have been moving on foot, who have been using bicycles and motorcycles when authorized by the local communities to be able to reach the farthest point to deliver the medicine. Where need be, the national task force has been giving some food relief, and also ourselves would get some food relief, put in the medicine, and then also the food relief we be able to deliver on food. Particularly, I've been participating with my colleagues. The other thing we have been doing, you know, that my region is heterogeneous, has different languages. We have been trying to, you know, try to explain the local context. What is the information? What does it mean, viral hepatitis in this lockdown? Definitely in our local languages as we undertake some of these assignments. The other thing is that we have also been able to bring in the district task force to know that even when they prescribe solutions to the challenges of other health challenges, they must not miss out on the issue of viral hepatitis. That's the much we have been doing, and I'm happy that I've been able to express some of these challenges to different stakeholders. Thank you very much. Those are some of the challenges. But the most important thing which I wanted really, Cary, to interest you in is that we work within the vast group and community here in Kasese, and I'm happy that I've been able to talk with the resident district commissioner, the political leaders, to explain the plight of so we are doing the screening and doing also the vaccination, because government has been able to provide that. Thank you very much. I thought that is very, very important to also share across board. Thank you very much.
Absolutely. Thank you so much. And it's just so inspiring to hear about the amazing work that you guys do there and in such challenging circumstances. I mean, it's really fantastic, and really thank you for sharing those stories. So we are running a bit late, so unfortunately I'm going to have to move us on. So I'd just like to thank Professor Muhammad Ali and Arafat both for being part of that section. Thank you very much. And so just to conclude, I'm just going to, Philippa and Sue are just going to rejoin the panel for a final question. So I think we've heard so much about shared experiences that we all have across some of the challenges we all face, and some really amazing solutions. And just goes to show the power of the civil society that our members, WHM members, have to rise to challenges and to find creative ways to serve their communities. And really that they'll really, go above and beyond to make sure that their communities are looked after. So thanks to everyone who has tuned in and has shared their stories. But just as a final thought, I mean, I think it's, this has been such a terrible crisis around the world, but I think just to try to end this this session on a positive note, I'd just like to ask Sue and Philippa, what is one thing from the current crisis which you think could have a positive impact on hepatitis elimination going forward? So maybe Philippa, would you like to start?
Yes, thanks very much, Cary. And I think these are all points we're constantly reflecting on, and some of the answers I might have given a few weeks ago are now different. I mean, I would say just three key things. I mean, first of all, the message is coming out loud and clear about preserving essential health services and putting plans in place and ensuring governments, communities, and others in this laser-like focus on COVID is not to the exclusion of everything else. And so I think that message is being heard loud and clear, because the impacts from not ensuring a balanced portfolio in the delivery of services is knock-on consequences down the road, and for hepatitis also. I think we're learning about the importance of infection prevention and control in hospitals, and it's a renewed opportunity for a focus on the importance of good infection control procedures and behavior change in the population. And I think the third point, because I know Sue will pick up on the telehealth issue, is this renewed focus on case finding and testing strategies and use of diagnostics. You know, who you test, where you test, what test is used. And it's certainly exposed confusion and fragility in our testing infrastructure. And we know that from hepatitis, that the case finding and the optimal use of diagnostics was the area that we didn't do so well in, and countries struggled with. So I think this is an opportunity, and as we move forward with the vision of elimination, we've got to be very systematic. General population testing approaches, reaching the communities, we know that can be done. And so how we can partner with the kind of general population COVID surveillance going on in terms of immunity and antibody testing is another angle, but we need to get our testing approaches right, and we need to make optimal use of the diagnostics. And what we're already seeing now, the sharing of GeneXpert, the use of multi-platforms for COVID, works well, and it just needs to be now embedded in the culture of country diagnostic services. Thanks.
Thank you so much, Philippa. Sue?
Yes, thanks, Cary. This is a great question, and something for all of us to think about in the work that we do in our communities. So I think one of the big overarching things is that there's now an increased awareness and appreciation in our society for infectious diseases and how critical testing and access to care and treatment are. It's in our face now with COVID. But these are tools that we in the hepatitis community have become very familiar with. And as we talked about gaps and access to care in vulnerable populations, this is all coming up with COVID too. So I think our governments and decision makers are now more attuned to the impact of good screening programs. And we have to really push for better integration of screening programs to include hepatitis. And as Philippa mentioned, having really centralized, strong healthcare systems is becoming very apparent as well. I also think it's interesting, there have been a number of anti-stigma campaigns for COVID. And I'm hoping that there's some spillover from those. I've seen WHO push some solidarity, not stigma campaign. I've seen the tagline, racism is a virus. And I think these are really good things for us in hepatitis to also, help broadcast. So importantly, COVID has really forced us to think outside the box. I think a lot of these modifications of services have been exemplified today. And a lot of them are actually a lot more patient-centered. So telehealth, as we talked about, is a really big one. COVID saw a lot of lifting of restrictions and regulations. I mean, we saw medicine really just change overnight to allow patients to be able to be seen from their home, even providers providing care from their homes. Even apart from COVID, a lot of patients face barriers to coming to see us in the healthcare system, including transportation. And we think a lot of these measures, such as telehealth, are hopefully will continue so that we can continue to reach people for hepatitis elimination. So a lot of these out-of-the-box efforts are coming from people like you. And I just want to address our members and our community. You all are the ones that are passionate to serve our communities. We're so inspired, as Cary said, to really see how our members are filling these gaps and meeting the many needs, whatever they are, even if they're not hepatitis related. In times of crisis, we are seeing amazing adaptability, and we believe the Alliance members exemplify this ingenuity, and we really want to celebrate you during this time. So thank you all for being here. We at the Alliance are here to support you, our members, and the communities you serve, however we can, and we really look forward to future collaborations. So thank you.
Excellent. Thank you, Sue. And that really sums it up. It finishes off very nicely. So Thank you all very much, and thanks everyone who's participated today. Could I just have the next slide, please? So this is, we're going to be doing a series of webinars now in this new Zoom age that we're living in. So please keep an eye out on our social media and other channels about future seminars that are coming up. Here's just a few of them. We're going to have a dedicated one on COVID and harm reduction services, one dedicated to mother-to-child transmission, one about meeting the needs of hard-to-reach communities in the context of UHC. We just call them our communities generally. And then looking again at the impact that COVID's had on hepatitis elimination, and really, where do we go from here? How do we transition as we transition out of maybe the acute stages of COVID? How do we move forward? I mean, I think we've kind of seen, and we know that a lot of the things that are going to be needed for an effective COVID response going forward, the engagement with communities, providing mass community screening and vaccinations, and all of these things are all things that, hepatitis organizations and WHA members around the world do every day. So, I mean, it's really our hope and our intention to ensure that, hepatitis organizations are at the center of the response, and that not only do we play our part, but we really ensure that hepatitis elimination is also carried forward as we work toward 2030. So thank you all very much. This has all been saved and recorded, and will be available on our YouTube channel, and will be advertised in social media and on the COVID-19 hub on the website. Thank you all very much, and that's all for now. So thank you. Have a great day.
Bye-bye.
Bye, everyone.
Thank you.